Today, we will discuss about glabellar reflex. Glabellar reflex is a primitive reflex. It is also called as glabellar tap reflex or glabellar tap sign, glabellar blink reflex, supraorbital reflex, nasopalpebral reflex, orbicularis oculi reflex, trigeminofacial reflex, McCarthy's reflex, and Myerson sign. Persistent glabellar tap response is called Myerson sign after the famous American neurologist Abraham Myerson. Coming to the historical aspects, it was first described by Walker Overend in 1896, and in 1901, Daniel J. McCarthy rediscovered glabellar tap reflex. And Erik Kugelberg, the Swedish neurologist, studied the physiological mechanism of blink reflex by electrophysiological analysis of the reflex. And the word glabella is derived from the Latin word glabellus, meaning smooth, hairless. How to elicit the reflex? First, explain the procedure to the patient prior to its execution. It's elicited by gently tapping the forehead between the eyebrows and nose, that is glabellar area, with index finger with an approximate frequency of 2 taps per second. Examiner should stand by the side or behind a seated patient to avoid menace reflex, that is blink reflex to visual threat. Patient should be asked not to blink. Observe the blinking of eyes. Normally, successive tapping of glabella eventually leads to habituation, that is, termination of the reflex after few blinks. Habituation usually occurs within 2 to 4 taps. And glabellar tap reflex is said to be exaggerated when there is ongoing blinking without habituation at 5 or more tapping. Normal response is 2 to 4 blinks and then no further blinking due to habituation. And it is called a reduced reflex when there is no blinking in response to stimulus. Causes of reduced glabellar tap reflex include upper or lower motor neuron weakness like ophthalmic nerve lesion, facial nerve lesion, pontine or medullary lesion. Coming to exaggerated glabellar tap reflex, it's seen in supranuclear lesions of the corticopontine pathway and in extrapyramidal disease. It's a sign of frontal, diffuse cerebral, or extrapyramidal disease. Exaggerated glabellar tap reflex is seen during childhood development. Pathologically, it is seen in patients with Parkinsonism, dementia, advanced stage of neurodegenerative condition, diffuse cerebral hemisphere degenerative and vascular disease, senile and presenile dementia, widespread intracranial neoplasms, subjects with mental retardation, Alzheimer's disease, hydrocephalus, HIV encephalopathy, schizophrenia, diffuse axonal injury, encephalitis, severe cerebral anoxia, subarachnoid hemorrhage, and even in patients with migraine. But remember, exaggerated glabellar reflex is also seen in normal individuals. And it was reported that exaggerated glabellar reflex is present in 21% of normal individuals over 84 years of age. And another study showed that exaggerated glabellar reflex is present in 37% of people with 80 years and older. So how to differentiate these from pathological response? Primitive reflex of patients without neurological lesion is weak and fatigable, disappearing after the first few repetitive stimuli spaced evenly apart. Primitive reflex of patients without neurological lesion is an isolated findings. Coming to the mechanism of glabellar tap reflex. During glabellar tap, afferent impulse travels into the ophthalmic branch of the trigeminal nerve to its sensory nucleus. This projects to the motor nucleus of the facial nerve through three kinds of synaptic connection. First, a direct monosynaptic connection. Second, an indirect polysynaptic connection with the contralateral facial nucleus. Third, a polysynaptic connection to the ipsilateral facial nerve nucleus. And facial nerve innervates the orbicularis oculi muscle, causing the blink. So there is suprasegmental influence on glabellar reflex from the cortex and basal ganglia, and damage to these structures modify the reflex response. So sustained glabellar reflex is a release phenomena resulting from either loss of inhibitory effect of dopamine on the striatum or from diffuse cortical dysfunction. Kugelberg conducted an EMG study and found that the glabellar tap reflex is characterized by double response, which was measured by a recording electrode placed in the orbicularis oculi muscle. And the characteristic of the first response corresponds with those of monosynaptic myotactic reflex, and the feature of the second component are those of multisynaptic nociceptive type reflex. It was also found that patients who received L-DOPA for Parkinsonism, there is reversal of glabellar tap reflex. And the reversal of the reflex is seen in those who had good clinical response to levodopa. And reversal was less frequent in those with more advanced disease and those with disease longer than 10 years. So reversal of glabellar reflex is of theoretical importance because it is the first reported instance where a reflex resulting from structural changes within the brain could be reversed by a pharmacological agent. So to conclude, glabellar reflex is a primitive reflex. It's commonly described in Parkinsonism. Thank you for watching this video.